All right, sorry about that. Hi, everyone, and welcome to the briefing webinar for OASAS certified programs on the status of managed care claiming. Basically, we're going to go through the presentation, hearing from OASAS, hearing from ourselves over here at MCTAC, the plans, and Millen, and then we'll answer all of your questions at the end of the presentation. So I know some people are having trouble with audio, first off. If you need to still call in, you should be able to, on your main screen, you should see a box that says connect to audio, and if you click on that, it should give you the call-in number and the access code, just in case anyone's still having trouble. In addition to that, in order to send us your questions that we'll answer at the end, use the chat feature as opposed to the Q&A feature. If you just chat your questions to all panelists, then we'll get them and record them and answer them at the end. If you're having any technical issues throughout the presentation, you can feel free to chat the host directly or Brianna. I don't know what it pops up on your end, and we'll help you with all of that. And then just the last thing before we get started, if everyone can just mute their phones when they're not speaking, that would be great. 1 second.
Don't worry about it.
All right. So yeah, I guess we'll go ahead and get started.
So hi, I'm Pat Lincourt from OASAS, and I just wanted to go over the agenda, and then I'll hand it over to Rob Kent, who's going to open this up. We're going to do some opening remarks from the state, give some overview of what the process has been from our point of view. MCTAC is going to talk about some of the initiatives they have addressing billing and claiming and some of the things that they may have coming up. And then there's some updates from plans that have put together some tips and ideas for billing and claiming to help providers to be sure to be submitting clean claims that get processed and paid. And Millen also has been working hard with providers and plans to identify some of the issues, and we'll also have consolidated some tips for providers. And then we'll spend some time responding to questions. So I'm going to hand it over to Rob.
Great, thanks, Pat. So, good afternoon. I just wanted to give a few quick remarks. First off, so we made the transition. I think some people still doubted it as of October 1st, maybe even October 2nd. And so we're in New York City. We went into it trying to do as much as we could up front, claims testing, everything else, working with plans. But, you know, understand the context. Unlike mental health, where most of their services were in, there were a few, you know, and they weren't their major services, but a few that weren't in, we were bringing our two most major services, our largest, outpatient and OTPs, into this system. We knew there were going to be challenges, and so we tried to work before, and, you know, I thank Pat and Eliana because they've been working nonstop since to address the issues that have come up related to ensuring that, you know, like I said all along, the two most important things, people get care, which doesn't seem to be an issue at all, and that providers get paid. And so we know for a fact that providers are getting paid in all the different modalities by multiple plans. All the plans are paying claims. There are issues, some are on the provider side, some there's just technical things we're working through. So we're not surprised by what happened, and I can tell you that I've spoken to folks at DOH who've, you know, implemented all the major transitions into Medicaid managed care, and they indicated that they've seen nothing that, you know, that's any different than the transitional issues they've addressed or dealt with in other carvings of benefits into Medicaid managed care. So with that, I want to thank the plans for working with Pat and Ileana nonstop to fix issues. I want to thank Millen and the other clearinghouses for also stepping in and assisting us, and the providers for making us aware when there are issues. You know, we set up the mailbox, pick'em@oasis.ny.gov, because we set up a process to, you know, to handle the inquiries, to you know, make it efficient, and I think it's working. So again, you know, you'll go through some stuff today, and it's good that we're doing this, but you know, like I said, there were issues, and we know there are some. We think we're working through them. They are not systemic. So I think, you know, all things being considered, we're in a really good place, and that's thanks to the hard work of a lot of people. So with that, I'll stop talking and turn it over to folks to carry this forward.
Thanks, Rob. And I echo what Rob said about the hard work of multiple people. We're appreciative of the providers who were out front, who identified issues, of the vendors who were out front and identifying some of the issues that came with the transition, and to the plans for every single one of them that we reached out to has been on top of very quickly, as possible, fixing the issues as we identified them. So, you know, not to you know, belabor that point too much, but I do appreciate, and I appreciate the providers who are participating today, and the providers who have sent us email and phone calls, you know, both on some of the good news that they have, and also on some of the problems that they've encountered. At this point, we can report that all of the systemic large issues that we're aware of have been resolved, and we're anticipating that going forward that these glitches, having been worked out, will be fewer and farther between. So, Ileana?
Sure. And just to echo what Pat and Rob were talking about as far as really acknowledging the collaborative relationship between the providers, the vendors, and the plans as far as early identification of issues and working through. And one of the things in particular to note, both with the initial identification of issues and their associated solutions and ongoing, is providers have been very mindful of bringing us the level of specificity needed to facilitate the plan's ability to actually research the nature of the particular problem. So just wanted to acknowledge that that level of specificity has been key to helping us work with the plans to research the issues, and going forward as providers continue to work directly with the plans and with MCTAC, as Carla's going to start to speak with, that level of specificity continues to help us research and triage issues. So again, thank you very much, and now we will turn it over to Carla Licio from MCTAC, Casa Columbia, to speak a little bit about the ongoing support that we're doing with the field to facilitate claims issues from this point forward.
Thank you, Ileana. This is Carla Licio, and welcome. So I just want to review, I'm sure many of you are familiar, but I would just like to take a minute to review some of the initiatives that Casa Columbia and Managed Care Technical Assistance Center have put forth regarding billing and claiming issues. I think many of you are aware that we have put together an integrated billing guidance, which is one set of guidance for all of the plans and for OMH and OASAS. This was a real opportunity to collaborate closely, and I think that this will be incredibly useful. You can find this, if you're not familiar with it, the integrated billing guidance can be found on the Managed Care Technical Assistance website. There will be updates to this within the next couple of weeks on a webinar. So again, thank you to everyone involved in making that happen. I think that this really is a useful tool. In addition, some additional billing training that we have provided is the HCBS-specific billing training that will be coming in December. We also intend to develop program-specific billing webinars that will be delivered as needed. Today, these are not fully developed yet. We really need to see what the field tells us about what's needed. In addition, the Managed Care Technical Assistance Center is involved in a number of separate forums to make sure that we stay on top of and address billing issues as they arise. Again, we work very closely on all of these initiatives with OASAS and with the plans, and it's been a very collaborative process, and I think there's been really good product on that. So thank you. And at this point, I will be handing it over to Beacon.
Hello and good afternoon, everyone. My name is Barry Castle. I'm the Provider Training Manager here at Beacon Health Options. So we want to thank you for taking the time this afternoon to join us, and to those who spoke before me, thank you for their remarks and hosting us this afternoon. So we want to go through some claims bullet points, or sort of claims reminders that could help you with getting your claims paid and processed appropriately. So if we look at our next slide, we'll see that we have some information we'd like to go over with you. So you want to make sure, when it comes to billing your claims, you want to make sure to register all your sites with Beacon and keep us updated of any changes. So that's very important to make sure that if you do have a site that you've added recently, any information regarding that site, that you keep us updated with that so we have it updated in our internal system. You want to make sure to validate that the member is eligible, both through the plan and for the new services. You want to go online or contact our customer service folks to make sure that that member is eligible so that you can get reimbursed for these services. You want to make sure that the claims that you submit contain valid ICD-10 and DSM-5 codes. Very important when it comes to billing, especially now when the switch over to ICD-10 and DSM-5 as of October 1st. So you want to make sure that you're using valid codes. I know that the CMS websites have a whole host of crosswalks and guidance with those, along with Beacon's website does as well. You want to make sure that you're using the correct MPI number. So when you're billing your claims to us, you want to make sure that you're using that correct MPI number for the site and for the rendering clinician as well. You want to make sure to submit your claims within the plan's timely filing limit. Those timely filing limits can vary by the plan, depending on which one you're submitting the claim for. So you want to make sure that you get it to us within that time frame. Even if it's just 1 day over that filing limit, it will trigger a denial. So you want to get it to us within that time frame so that we can get it processed and paid for you. Make sure that you have an authorization on file if necessary. So if the services that you're submitting for do require prior authorization, you want to make sure that you have that in place before you submit your claim. If it is a service that does require an authorization and you submit it to us and there's no auth on file, that's going to trigger a denial. That's not what we want to see happen. So you want to make sure that that service does have an authorization if necessary. You want to monitor any claim rejections and resubmit with corrections regularly. So when you do get your claim reports, you want to go through those. If you see denials, you want to make sure that you resubmit those to us in a timely manner as well, with corrections. So even if your claim did deny, you can still resubmit it to us as a corrected claim and still get paid for those services. So even though it may have initially denied, you still have the opportunity to resubmit that as a corrected claim and not lose any money on getting for those services that you rendered. And also use our resources if you need assistance. You can always reach out to our provider relations staff, our member services department, our claims departments. Please don't hesitate to reach out to us, whether that's over the phone or via email. Reach out to us and ask questions. If you're not sure what you should be doing or how to proceed, ask us, and we're more than happy to help you, provide you with guidance and assistance on whatever you may need when it comes to billing claims or if it's just questions in general. We have a few more points on our next slide. So you want to make sure that you use the correct value codes for those services. Those are needed for APG processing. So we would ask that you please reference the MCTAC billing slides for more information on the value codes, but you want to make sure that you do use the correct ones. Please make sure to use KP and HF modifiers as appropriate. There is additional information that can be found on page 34 of the State Billing Manual found at this link below. So that's on the omh.ny.gov website. I'm not going to bore you by reading every single word of that link, but you can see that the link is listed there, and you should be able to click on it if you get a copy of this presentation and follow right to that. Also, make sure to use correct form type. APG reimbursed services should be submitted on the 837I for electronic submissions and the UB04 for paper submissions. So that's a very important point to make sure that you're aware of, that you're using the correct form when you're submitting for these services. So those APG reimbursed services, you do want to make sure you're using that 837I for electronic submissions and UB04 for the paper submissions. You also want to avoid submitting the same billing and rendering MPI. So you want to make sure that you're using your site MPI number as your site MPI number and the rendering clinician's individual MPI number as that rendering clinician's MPI. You can't use both MPI numbers when you're submitting a claim. You can't have the site MPI number or the billing MPI number be the same as the rendering clinician MPI. Those are two separate MPI numbers. Those trigger denials, so you want to be very cautious about doing that. Claims for medical issues such as lab and pharmacy should be billed to the health plan. So these are other things that can affect your claims performance and also getting you reimbursed for those services. So if it is a medical issue, labs and pharmacy services, you want to bill those directly to the health plan so that you're not billing them to Beacon first, waiting for us to send you a denial, and then having to submit it to the health plan, submit it to the health plan directly first. VNS and MOOM claims should be submitted directly to Value Options for faster processing. They are being rerouted now, so if the claim does come into Beacon, we are forwarding it to our colleagues at Value Options so that your claim still gets processed, but in order to get it processed even quicker, if you are seeing those VNS and emblem members, submit it directly to Value Options. On our last slide, we have some contact information. So again, as I mentioned earlier, if you need assistance, please don't hesitate to reach out to us. We have our provider relations contact info listed here. Please call us. We have an 800 number, 844-265-7592. We have our email listed here, provider.relations@beaconhs.com. And we also have our e-services assistance as well. So if you're billing claims electronically through the e-services portal, if you have questions or concerns, you can always contact us through those numbers or via email as well. And we also have our claims hotline. So if you are having questions about what you need to have on your claim forms, if you need assistance with submitting your claims, questions in general, please don't hesitate to utilize any of these resources that we have listed here for you. We're here to help you with getting through this and getting your claims processed and paid appropriately. So don't be afraid to contact us if you have a question. That concludes our piece of the presentation, and I'll turn it back over to Carla.
And next on our list are the folks from Empire Blue Cross Blue Shield. AmeriGroup, are you there?
Hello, can you hear me?
Yes, terrific, okay. Thank you.
Okay, so sorry. So as I was saying, what I'm sharing with you really in this slide, the next slide, just our claims experience in the month of October and our findings and some of the lessons learned. We've received many claims and for the most part, the payments have gone through quite well. Some of the barriers that we found where we had some challenges with processing the claims or making payments rather was related to the revenue codes. the revenue codes that the providers were using when submitting the claim did not match the revenue codes that we have in our system. So that created some challenges, and we've been outreaching providers to give them information on what we have in our system, so we can make sure that those revenue codes are used and claims can get paid. The second reason why we found last month why we were issuing denials was that providers were submitting claims without the rate of the value codes within the claim. So that was resulting in some denials. Overall, there were some challenges because some of the particularly some of the CPT codes that we use was also used for other services. So it's like the same CPT code for a couple of other services, and for once, like this CPT code H2019 for one particular level of care needs authorizations, and for another doesn't need authorizations. So that was causing some problems as well in terms of making payment. In terms of lessons learned, and what we would recommend is that it would be really helpful for providers to learn how to resubmit a claim. Sometimes when a claim is denied and it's sent again for reprocessing, if the system can read it as a duplicate claim if it's not correctly marked as a resubmission. So a suggestion would be to make sure that providers know how to resubmit a claim. The two other points related to the lessons learned was the work done with MECTAC, the work that we did with MECTAC on claims, I think has been very helpful and is a great resource. I would really recommend providers to use the resource because there's lots of information on how to submit claims, not just for one plan, but for all plans, all consolidated, and lots of great information with MECTAC. And, now that we've gone live, I think it would have been really helpful to have started our claims testing earlier. And if we could have done that and also had more participation, that would have been very helpful. And, that summarizes our findings for, in terms of claims and some takeaways on lessons learned. So, thank you, Carla.
Thank you, Radhika. I think we have Health First next. Health First? Anyone from Health First there? Okay. We could, this is Carla Licio again from MECTAC, and if Health First is unable to join us at this time, they did provide us with information, and we could walk through the slide. Ileana, does that sound like a plan?
Hi, everybody. I see a representative from Health First is logged in. Perhaps they just need some instructions from MCTAC CASA on how to unmute so they come into audio.
Oh, there she is.
Oh.
Yeah. She just took.
Where's the start? What? Wait,
What?
pound something.
What? Yes. What is it?
Hi to the Health. Hi, Health First folks. We can hear you.
Oh.
Thank you. That's great.
great. We were frantically trying to figure out how to get you to hear us. So we just wanted to start off by saying thank you for hosting this. We're very happy for the opportunity to have sort of a back and forth. We understand the anxiety that some of the billing and payment and claiming issues have caused across the board. And, you know, we know that there was nervousness on behalf of the providers prior to transitioning over. And we do know that, you know, folks were worried that they weren't going to be paid and they weren't going to be paid seamlessly. And I do understand that some of those fears have come to pass. And so what we wanted to do was just to take a moment to say that we are working diligently to make sure that you all can be paid for the services that you have provided. Our intent is to make sure that you stay solvent, financially strong, and are able to serve the members. You know, ultimately, our goal is the same as yours, and that is to make sure that the members get what they need and get it in a timely way, and that ultimately you're paid for that so that you can stay open and do that continually. So we just wanted to express that so that you understand we want to partner with you, and anytime that you have questions or issues, we do really encourage you to reach out to your provider representatives. And, you know, we'll talk a little bit more about that in a moment. But thanks for hosting, and without further ado, I'm going to turn it over to Kaylina Colon, who's going to talk a little bit about some of the issues that we have encountered on both sides of the fence and what we're doing to work through them.
Hi, good afternoon. Thank you for inviting us here today to discuss all of our concerns. Some top provider trends leading to denied claims are, first, as you can see, that providers are not billing with the proper rate codes. They're either not using any rate code or using the incorrect rate code. And so, you know, it's important that, that you use a rate code, and the rate code is a 4-digit number that is placed in the value code field. So that's the first trend we've seen. Another trend we are seeing is providers using ICD-10 codes before transition, meaning some providers on the UB04 box 6, it requires, you know, that providers put a date range, and it's important that the date range is 10/1 and after, and not before 10/1. And then in general, just use ICD-10 codes. Another challenge that we're facing is that when providers resubmit denied claims, they're denying as duplicates, so it's important that providers learn how to submit corrected claims appropriately, and any additional training that is needed can be provided. And then finally, it's important that providers deal with modifiers. Oftentimes, these modifiers are only used for data collection purposes, but they're still an important part of the actual claim, and we're looking for that.
The one thing also that we wanted to add was, you know, similar to the prior two presentations, it sounds like the issues that we're all seeing are very consistent across the board. That, you know, these are the top issues that we're seeing. But we've also experienced claims coming in with the same kinds of issues as Beacon, as Empire, yeah. Okay, next slide, please.
So some challenges that Health First has been facing, as you probably know, from 10/1 to 10/31, we identified some programming issues here at Health First that denied claims inappropriately. So if you fell into this issue, you would have seen claims denied for the following reasons: carved out services to the state, service not in provider contract, or no authorization, service not authorized. These were incorrect denials, so Health First has fixed that. Another issue that we identified is that some of the claims were paid incorrectly, specifically around APG rates and specifically around a particular preventive promotion incentive. And these claims would have gone out with a $10 payment rather than the correct payment. So just be aware that we know this, we've reached out, and that we are reprocessing these claims. The system issues have been resolved, And as we've been experiencing these issues and challenges, we've gone out and we've called providers, and we will continue to collaborate.
Okay, next slide, please.
So some lessons learned and next steps. What we've learned is that communication is key. The behavioral health transition is a challenge we're tackling together, and without communication, you know, this wouldn't be a success. So as you see concerns or as you experience any unexpected challenges, please feel free to reach out. Health First is doing ongoing education, and we realize that education is a process, and we will be doing that together. Leverage your dedicated behavioral health representatives. All of you have behavioral health representatives from Health First who are dedicated to answering your questions and to going on-site if necessary. Please use them and ask questions. It's also important to sign up for the provider portal. On the provider portal, you'll be able to see lots of great information, including your claims, your authorizations, eligibility for members, and then the managed care billing guidelines are a great resource, have lots of information. Just like previous presenters, we certainly think that you should look at these. And then finally, the MCTAC trainings. MCTAC trainings are important and will also give some clarity on a lot of these topics, and they give, you know, great resources. And then one thing that I didn't include here that I think is certainly vital for all of the providers is to please ensure that you sign up for EFT. If you need to sign up for EFT, you can reach out to myself, Kay Colon at healthfirst.org, or your behavioral health representative, and they can assist you with this process. This will allow for quicker, faster payment rather than waiting for the mail for paper tax. All right.
Thank you. And now we have a presentation from Millen.
Okay, good afternoon. Can everyone hear me?
Yes.
Also?
Yep,
okay.
We're good.
Wonderful. This is Marcel Handler at Millen Associates. I know there's a lot of information being absorbed in a very short amount of time, so we'll try to keep it as short as possible. Some of you may already be on your second cup of coffee. So while there are probably many, many additional items that we can discuss and bring up, we wanted to bring up a couple of key features that we think will assist you in submitting clean claims. At the same time, we also understand that there are claims that have not yet been paid or been paid at the rate that you were not expecting, and you need to be able to follow up on those and how to manage your accounts receivable. So we're going to touch upon a couple of items. As you can see on the slide, the few bullet points. I'm actually going to give it over to Joseph Samet, who will delve into it a little bit more and elaborate on these points so that you can actually put them into practice.
Good afternoon. So the first thing that you want to keep in mind is that this behavioral health transition was for the adult population. So one thing you want to look at is the patient's age at the time of the date of service. So if you are a provider who services different age groups, make sure that for those patients who are younger than 21 that you continue to bill Medicaid fee-for-service, whereas if the patient is 21 or older, you would bill the managed care plan. So that information is available, as you know, on the eMedNY ePaces website. If you're checking one by one, it's also available in some systems on a batch eligibility response. Another thing you would like to ensure before you submit a claim is the county listing that's reported on ePaces. So as we know, this behavioral health transition only affected the New York City population. And I just wanted to clarify something which was a little confusing originally. it doesn't really pertain to New York City-based providers. It really pertains to the location of the patient's residence. So if you're, for argument's sake, a provider in Queens, servicing individuals who live in Queens as well as in Long Island, keep in mind that the patients who reside in Queens, those are the individuals who have begun to have carved-in services, bill managed care. The individuals who are being serviced by your clinic who reside in Long Island should be billed to fee-for-service until the managed care changes take effect for the rest of the state. Now, one thing you want to take a look at is the county that's reported on EPASES or eMedNI. So we've seen profiles, we've seen individual eligibility profiles where the zip code for the patient's address would be in Long Island, for example, but the county of fiscal responsibility is New York City. So if you see that NYC on EPASES, that's an instance where you'd build a managed care plan. So make sure to take a look at the county. Don't take a look at the address of the specific patient. Another thing that you want to keep in mind is the contracted address. So if you're a provider which has one paid-to address, one headquarter, one main location, but your service location is elsewhere, you want to make sure that your claim to managed care reports as the billing provider the actual service location and the appropriate zip code of the service location site. This is similar to the way claims were submitted to Medicaid fee-for-service, but managed care plans will edit the same in the sense that if you have a paid-to address in Long Island, but what's on file with the payer is a location in Queens, you want to make sure that your billing location on the claim itself has the New York City, the service location. Another point that's critical when using a clearinghouse, whichever clearinghouse is used, is you want to ensure that you're submitting the correct payer ID, the payer identification for each payer. So the concept of a clearinghouse, as you all know, is you give a clearinghouse a batch of claims for the 10 payers, and the clearinghouse routes the claim to the appropriate payer based on the payer ID that's on the claim. So there was discussion earlier on the call about some plans having medical primary care visits administered and processed by one payer and behavioral health benefits processed by another payer. You want to make sure that you're submitting the behavioral health services to the payer ID that's unique to the behavioral health administrative payer. With some payers, if you're sending an institutional claim, which is the format that's required to be submitted, the payer ID would be different than if you would be submitting a professional claim. So rate codes should be included on institutional claims, but make sure that the payer ID that you're submitting to the appropriate plan is the payer ID that the plan wants from the clearinghouse. Next slide, please. Okay. So assuming you got a clean claim out, there are a number of points to keep in mind just to track where the claims are, as well as payments and denials. So one thing that's really key is ensuring that the payer actually received the claim and process the claim. And that's something that we see providers get confused between the term rejection versus a denial. A rejection typically is used by payers to indicate that the claim never hit their system. So for example, if you submit a claim with the invalid member identification number, that claim may be rejected and may never be processed. So you may never even get a denial. Whereas in other instances, claims will pass through, but the clearinghouse will report a warning message that indicates there was something about the claim that didn't look 100% clean, but in reality, the payer did adjudicate the claim. So when you're using a clearinghouse to submit claims, make sure to identify that the claim was accepted, and if you're getting a message that the claim wasn't fully accepted, distinguish between whether it was really rejected, it wasn't processed, or it was processed, but it's almost like a dummy rejection. There's a warning message that make sure to submit a clean claim the next time. Another key point to keep in mind is how are you going to receive your remittances? Will they return for those claims that are actually adjudicated, they are accepted, they have not been rejected? Are you going to be receiving them on paper, or will you be receiving them electronically, referred to as ERAs, 835 files? If you are receiving them on paper, keep in mind that some plans may send those paper EOBs to the service site, some plans may send EOBs to the Pay-To address site, and some plans may send to both. If you are receiving claims electronically, make sure that the claims post appropriately into whatever software system you are using. Now, keep in mind that some clearinghouses and some payers have agreements in terms of whether enrollment forms are required before the clearinghouse will submit the claim to that particular payer, or whether they'll submit it without enrollment forms. Keep in mind as well that if you're a non-participating provider, some plans may not accept claims from you electronically unless you enroll. Okay. And as payments are coming in, you want to ensure that you're being paid the appropriate rate. So to really ensure that you're being paid the appropriate rate, you want to ensure firsthand that you're submitting the correct charge. So the advice of the state has always been to use the 3M grouper or a replica for generating a charge that's in line with APG government rates. And the rules of reimbursement in terms of APG is quite complicated. It depends on the rate codes, it depends on the procedure codes. In some instances, it's the primary diagnosis that drives the reimbursement. So you really want to ensure that the charge you're submitting is in line with the APG rates, the government rate. If you do so, if you submit the APG charge, typically on an electronic remittance file, the payer will return a claim adjustment reason code, a CARS code of CO45. CO45 is an adjustment code that's returned on remittance files that indicates that the charge amount is different than the paid amount, than the allowed amount. So if you believe you are submitting the correct APG charge, but you're seeing an adjustment code of CO45 return on your remittances, that's a flag for you to contact the plan to ensure that your claims are reprocessed at the appropriate rates. One thing just from a workflow perspective that's really critical is to keep a record of when claims were submitted. So not only should you keep track of dates of service, keep track of the actual submission date. So you can follow up with a payer and say, hey, we submitted this claim and such date. It's been over a month since we received any remittance or validation. It's very important for you to prioritize and sort your claims follow-up based on when the claims were submitted. And as was mentioned earlier, we can't stress this enough, is you want to follow each payer's guidelines for rebilling denied claims as well as adjustment claims. So in the Medicaid fee-for-service world, historically you were able to just rebill a new claim as if it was a fresh claim. There were appropriate delay reason codes in some instances. Some of the managed care plans on an adjustment claim or a rebuild claim will deny unless you reference the payer's claim number in the appropriate box on the UB on paper or in the electronic field. So make sure that you follow up with the payer to ask them the specific requirements in terms of how do you rebuild a denied claim? Do they need the original claim number, what was called the TCN for Medicaid fee-for-service claims, or for an adjusted claim. So say a claim actually was paid, but you realize that you submitted the incorrect CPT code. You want to send a new claim with a corrected CPT code. You want to ensure that claim doesn't deny or reject as a duplicate, so you just want to make sure that you're following the payer's guidelines in terms of including the appropriate fields in the appropriate places.
Thank you so much, Marcel. Ileana, before we get to questions, this is Carla Licio again from Casa Columbia McTac. I would like to just make sure that everyone on the call knows that the slides for this presentation will be available on the MCTAC website, which is www.mctac.org. And now we can head into questions.
Okay, so we're seeing some questions in the chat and a couple things just high level in terms of whether or not, questions about whether or not the plans are required to pay the APG prices, and they are. And so, you know, as Joe just talked about, if you are seeing a difference in your charged APG price from the, you know, what you received on the EOB, you should reach out to your plan representative to talk about that. Also, the rate code, the Medicaid rate code is the code that in the 3M grouper does the calculation for your peer group times the weight of the service. So it is your program rate code that does that. There was a question about that. And then also there have been a number of questions about how to bill, you know, how to use an individual NPI for a KSAC or a non-credentialed counselor who does not have an NPI. And we issued guidance on that, and with we will be sharing that with MCTAC to post on the website with that. We're not going to get into the specifics, but we have very specific guidance for you on that. There's also a number of questions about another thing that Joe had mentioned in his presentation about getting a warning note from Clearinghouse rather than the denial. And so people are receiving some warnings from the Clearinghouse when they bill to a plan. There are plans that may have individual connect to issues with clearinghouses, and they're trying to reduce the inaccurate warnings. But in the meantime, those plans, you know, those claims are being cleared. I don't know, Joe, if you wanted to say something about knowing the difference between a warning and an actual rejection of a claim.
The difference between a warning and a rejection in this context is a rejected claim refers to the fact that it was never processed. So an EOB will never be generated. If you call the claim call center, they'll say we don't have a claim on file for that patient and that data service. A warning message is when a clearinghouse will report back that you know, this claim doesn't seem to be an appropriate claim. We've sent it to the payer for them to process it, but you may want to really follow up with the payer to see if it was adjudicated by the payer. So there are instances, as Pat just mentioned, where the clearinghouse will indicate that the claim wasn't adjudicated. It's just an accurate warning message. If you were to call the payers, you'll see that the claims are on file. So our recommendation really is when you see a rejection message come back from the clearinghouse, follow up with the payer to see if they actually have that claim on file or if not.
Great, thanks so much, Joseph. And as what's happening is people are submitting questions to, and we're reviewing them. And I just wanted to share with people, there was a question about how to review county listings on eMedNI, and I just want to, this is Ileana from OASAS, sorry, and I just want to flag to the group that we will share with MCTAC Casa Colombia the link to the overall New York State eMedNI website, and that has a variety of links and training opportunities to tell people how to read the eMedNI screens, including but not limited to how to identify what county someone is coming from in order to determine if they're coming from a county where the service is currently carved into the benefit package or out of the benefit package. So we'll go ahead and send that link out afterwards with the other materials that we've talked about, including the posting of the PowerPoints.
So some of the other questions that we're getting are specific to specific plans, and I think the plans that are on this call will be able to take them back, and so providers should reach out directly when there is a specific plan concern that or a specific issue that's happening between your plan, you as a provider on a plan. And we can confirm, one of the, a recent question is, please confirm that the claims, Ileana, you moved it. Sorry. That the claims are to be paid APG rates even for out-of-network providers. That's correct. There are continuity provisions in the plan contract that if you're not an in-network provider during and you have a current patient in treatment that up to 24 months, you should be paid by the plan. If you're taking a new patient who's a member of a plan and you're not in network with that plan, you do need to reach out and have a single case agreement with that plan. So if you're taking new people in, the continuity provisions don't apply to that. So new as of from October 1st.
So, folks, we're just going through the questions just to look at ones that we have not already addressed that are probably of interest to the group in the main.
So one of the questions was that some plans are denying that second service in a visit, and the plans are required to pay for services with the same discounting rules that the government rates have. So that's a nuance. The plans are also using either the 3M grouper itself or a replica of it. You should reach out to your plan representative if you're seeing that denial on the second service. So the rules should be the same for the services that do pay, and the discounting rules should apply. And here's, has anybody begun providing adult home and community-based services at this time? If so, how is billing payments done? So nobody, adult home and community-based services provision will start January 1st, 2016, and MCTAC has been doing a series of webinars around the services and the billing. So I don't know if, Carla, if there's anything that you wanted to add about that.
Thanks, Pat. No, we've been doing some very specific trainings on the services themselves, which includes billing guidelines. However, we will be doing more training on HCBS in December, so look for that on the MCTAC website.
So we're also just to clarify that if you have reached out to your plan representative and you're not, you haven't been able to resolve, the OASAS and Department of Health are both, have email that is monitored regularly. For OASAS, it's that Pick'em address that Rob opened with, PICM@OASAS, OASAS.ny.gov. And any concern with a particular plan or any concern in general with a change to managed care should come to us after, of course, you've reached out first to the plan to try to resolve it. I know that all of the plans, particularly around claims, have a lot of resource that has been put toward helping to resolve provider concerns, and so, you know, and they may also have a way of elevating concerns within their own entities, but we're happy to also, you know, respond to and intervene if there were issues that aren't being addressed. A lot of questions about MPI, so we will get that. That was an issue very early on. It was one of the first things that we identified as being a potential issue. We did reissue guidance, and we've made the changes in the MCTAC billing, you know, guidance manual. So that is, you know, something that we are. That we've actually resolved, and just you have to follow the billing guidance on the 837I for that. Now, we have a question here that's saying that we are hearing that 75% of all OTP claims are being pended. Is this true? The answer to that is no. OASAS is aware that a number of plans at the transition did do a routine pending of all claims to do quality assurance and to make sure, and that's not true across all the plans, but a number of plans use that as they bring on new business. They pen claims to identify the issues, some of the issues, and the plans helped us to, in that process, to identify a number of issues by doing that. But they weren't pended to, you know, to not pay. There is some pending happening to do quality assurance. We have met now with the plans, and all plans at this point are processing and paying claims and within the prompt payment guidelines, and you know, so that is something that is part of the contract and an expectation, you know, going forward.
So at this juncture, we're starting to see that the questions themselves are starting to slow down. So one of the things that we just wanted to make sure people were hearing out of this presentation is that the MCTAC resource has the plan-specific information for providers to reach out to plans specifically for their own issues. So we want to encourage people to use that resource. And we just had a couple more questions that were coming in. We can address those. And one moment, please.
So one of the comments that came in is that people have heard that authorization is needed for all service types after 30 days from October 1st. That's not true. There is utilization management guidance that is out there, and we can also point you to that. But for ambulatory services, for SED providers, there is no authorization after any amount of time for an initial. And we describe also the concurrent review policy and procedure that we're in, you know, that's part of the contract as well. And then it says, will pre-authorization be required at any point over the next 2 years for carved-in services that are currently not requiring authorization? And, you know, the important part in that question is that are currently not requiring authorization. And the answer to that is no, that for the carved-in services that do not require authorization, we're not anticipating any change in that. But we do anticipate that there will be, you know, an opportunity for clinical management of cases, as well as some review that's based on clinical triggers. So that is laid out in the utilization management guidance, and we can provide that as well. Is there a managed care model contract? That's the last question we have here, and we probably will wrap it up on this one. There is a managed care model contract. There's the one that's currently in effect is available at the Department of Health website. And then there is the changes that have been made to that managed care model contract in consultation with the Department of Health that has been reviewed and accepted by the plans. However, it has not been released, and it has not yet been approved by CMS. In the interim, the plans will abide by the rules that are in that model contract, and they're, you know, they're held to the rules as they're laid out in the contract. OASAS did issue a one-pager that identified the important sub-clauses, and if Ileana would just...
Sure. I think by now people have heard there were several modifications made to the existing Medicaid managed care model contract to effectuate bringing in the behavioral health services into the benefit package. Those things included, but were not limited to, things like the government rate for 2 years, use of the locator for level of care determinations. We had previously sent out to the field a table that highlighted the major changes and what they were. So when we resend out the information related to the use of the unlicensed practitioner number, we'll also include that information as well as a link to the eMedNI site for the folks that were asking about the county issues.
Great. So I really thank MCTAC for pulling this together, and very much appreciate the plans for also very quickly pulling together some of their lessons learned to be able to share with the provider group here. You know, their level of you know, engagement with us and resolving issues has been you know, very much appreciated, and thank you to Millen, who's been really out front in identifying some of the major issues. So thanks to everyone. We will get the resources out to you, and please feel free to reach out to the, please do follow the process of reaching out to your provider, the provider reps at the plans first when you are experiencing an issue. And you know, you can also at the same time make us aware of it, or if you feel like you're not getting resolution or you don't understand what's being said to you, please also let us know. Providers have also brought to us some issues that we wouldn't have been aware of that we were able to resolve for everybody. So you're encouraged to do that. Thank you very much.
Thank you.
Thank you.